Today. My name is Lilian Genga, a program officer working with National Cancer Control Program in the first pillar. The first pillar is where we have prevention, screening, and early diagnosis. So we are going to have our webinar today on dissemination of our strategy that was just launched recently. Our first, it is the third strategy, and the first dissemination was done last week on Pillar 1 and Pillar 2. So today we are going to have our second dissemination on Pillar 3 and 4. And if we don't, without wasting much time, I will allow our first presenter, who is Dr. Joyfrida Chepchumba, to take us through Pillar 3. Thank you and welcome, Dr. Joyfrida.
Hi, good afternoon. I hope you can all see my screen.
Yes, we can.
Okay. So my name is Dr. Joyfrida Chepchumba. I work with the National Cancer Control Program, Ministry of Health. I'm in charge of the third pillar. The third pillar is cancer treatment, palliative care, and survivorship. So as our moderator has told you, we recently launched the third cancer control strategy, and would like to give you a preview into the strategy just to show you what is contained, what our stakeholders came up with in terms of the priority activities and the strategies we need to implement in terms of cancer treatment, palliative care, and survivorship. So the overarching goal of the third pillar is to ensure timely initiation of comprehensive treatment, strengthening access to quality, sustainable care, and improving the quality of life for cancer patients. So as you're all aware, cancer is one of the diseases that the earlier you get it, the earlier you detect it, the better the outcome, as well as the earlier you initiate comprehensive treatment, the better the outcome for the patients. And we know for a long time the access to these cancer treatment services was really poor across the country. Would see patients waiting for up to 2 years to just get some services like radiotherapy. But as of now, we are really seeing a lot of improvement. There's so many cancer centers, both public and private, that have come up, and the quality of care has actually improved. So previously we had one national referral center, which was catering to cancer patients. That is the Kenyatta National Hospital. And as of now, we have 2 referral facilities, as well as 12 regional cancer centers. I'll speak more on that in the next slide. But needless to say, there's need to scale up services to achieve the SDG targets and reduce suffering and financial hardships. And the principles of cancer management, which guide this Pillar 3, is that it needs to be timely, it needs to be comprehensive, it needs to be affordable, and we need highly qualified HR. So those are very important principles in terms of cancer treatment. And as you are all aware, the cancer management modalities include chemotherapy, surgery, radiotherapy, nuclear medicine, to mention just a few. So we also have childhood cancer treatment. And on this, the ministry is trying to align to the Global Initiative for Childhood Cancer 2018, whereby we are trying to increase the survival rate of children to 60%. Averagely at the moment, it's at 20%, even in our setting. But in the In the Western countries, we are seeing up to 80% survival rate for children. So we need to work towards this through better access and better quality of care for our children with cancer. Also, as part of the guiding principles, we need to strategically ensure that our patients can benefit from the UHC reforms. This includes digitization of treatment, commodities and supplies, enhancement of NHIF care packages to ensure that patients do not incur out-of-pocket spending, which have been catastrophic, as we all know. Most of us have been part of fundraising for various patients who require to maybe go to India, or even if it's local, they need some money to top up to what the insurance is covering. So it's our hope that the NHIF cover can cover the whole treatment. In terms of palliative care, this is whereby the quality of life of patients is improved. And this is not, previously people thought palliative care is when the patient is at their end of life. But we are trying to sensitize everyone that palliative care is initiated from diagnosis. Anyone with a life-threatening condition, they need to get palliative care right from diagnosis. And this can be anyone maybe even from a road traffic accident or any other debilitating condition, they need palliative care. It is not just for cancer or maybe the communicable diseases. It can also be from trauma or from any other conditions. So we have the palliative care policy 2021 to 2030, and the implementation of this policy will see that our patients get the quality of life that they deserve. So from our last strategy, I'll just highlight some of the big milestones in terms of cancer treatment. So as I had mentioned, we had one referral cancer center, that is the KNH, but currently we have 3 referral cancer centers, that is KNH, MTRH, and KUTRH. And I believe you've all seen the state-of-the-art treatment facilities that are provided in these centers, which now you actually don't need to travel to India for this. You can get a PET scan in this country from a public facility. You can get radiotherapy, you can get surgery, you can get chemotherapy. So you don't need to travel out of the country anymore. In terms of the regional cancer centers, these are our county referral facilities. In 2019, 11 of these facilities were upgraded to become chemotherapy cancer centers. And in 2021, we were able to get 3 of these to become comprehensive regional cancer centers. So a comprehensive regional cancer center is one that offers the 3 main types of cancer treatment, that is surgery, chemotherapy, and radiotherapy. And I think this is one of the biggest milestones we achieved in the 2017-2022 strategy. Radiotherapy services were thought to be quite difficult to decentralize from Nairobi or from the major cities, but we actually saw through great partnerships, through great support by the Ministry of Health and other stakeholders, that it's possible, and we were able to open up a center in Nakuru, in Mombasa, and even in Garissa. And that caters to a very high population. All the people from northern region can get radiotherapy at Garissa, those from the coastal region, and this includes even people from private facilities. There's no other radiotherapy facility in the lower region, so they all go to the Coast General for these radiotherapy services. And it's all catered for by NHIF. And we're actually seeing there's a whole reduction in the waiting time that used to be there, whereby there was only one facility offering these radiotherapy services. So I think this was one of the biggest milestones in terms of cancer treatment from our last strategy. Then the other regional cancer centers, Meru, Embu, Nyeri, Machakos, Makueni, Kakamega, Jaramogi Oginga Odinga, and Bomet. These ones have chemotherapy in their facilities, as well as some form of surgery in some of the facilities. And this is also to remind us that apart from just the cancer treatment, there's also the cancer screening that is available at these facilities and diagnosis. It's a full package. So these centers are actually very active. So through collaboration with other stakeholders in this cancer space, I can just highlight one access program that has also helped our patients. And this is the program for CML, that is the chronic myeloid leukemia. Our patients received care at Nairobi Hospital for a number of years. And now from 2021, this program was decentralized to 4 other facilities: Coast General, Nakuru, JTRH, and MTRH, whereby the patients now don't need to travel all the way to Nairobi. They're able to get these facilities at their closest cancer centers. And for this program, the patients receive this drug free of charge. The donor is the Max Foundation, and they've been able to cater to all our patients who require this drug for over 20 years, actually. So it's a very big program that now we are decentralizing to the other facilities. Also, just to mention in terms of chemotherapy, we know this is also a very expensive burden for our patients, and the ministry was able to supply some essential chemotherapy drugs to these regional cancer centers, with the condition that patients receive these particular drugs at no charge. So their NHIF cover is not depleted from these drugs. They can cater for other drugs that have not been supplied by the ministry, but for the ones supplied by the ministry, the patients receive these drugs at no charge at all. So now let's go to our strategy, 2023 to 2027. The following are the strategic objectives that guided us in this new policy. So the first one, we need to develop policies and strengthen coordination to guide relevant standards for provision of quality cancer management. So on this, we're going to discuss the strategies aligning to policies and coordination. The second strategic objective is to improve availability and capacity of a skilled multidisciplinary team of oncology human resources for health across all levels of care. So here we'll be focusing on the oncology human resource that is needed. The third objective is to increase access to timely, comprehensive cancer care services. So when we explore the first objective, whereby we want to develop policies and to strengthen coordination. So the first strategy in this, we need to develop, review, and disseminate guidelines for cancer management. So from what we have, we are going to review what needs to be revised among the protocols we have. So for this, we have the cancer treatment protocols and the radiotherapy protocols, which need to be finalized and to be reviewed. We also have the guidelines for establishment of cancer centers and accreditation framework. This needs to be reviewed just to keep up with what is currently being practiced across the world. Also, we need guidelines for the rehabilitation of children with cancer, and we need to develop guidelines for the management of traditional and alternative medicine. We are all aware traditional medicine is a big area, especially for chronic diseases, whereby our patients feel that perhaps they need to explore more options in terms of care so that they can alleviate their suffering. Their families also become desperate and they want to just find alternative solutions. So we need guidelines for this so that we don't have patients going off the conventional medicine and coming back after a lot of damage has been done by using this traditional medicine. The second strategy, we need to enhance coordination, regulation, and standards for quality cancer care services. So some of the activities in this include development of centers of excellence. So these are facilities whereby cancer care is given to the highest level of excellence, where anyone can go there and do research. They can come and benchmark how best to implement cancer care. And other activities include strengthening of the technical working groups. So these technical working groups are groups of stakeholders in different departments across the cancer care continuum, and they assist in coming up with the best policies. They advise the ministry on what needs to be done, what services need to be offered at different facilities, and this is very important. So strengthening of the technical working groups is big. Also, we need to develop mechanisms for the establishment of multidisciplinary teams. Cancer care, as you're all aware, is not a one-man show. A multidisciplinary team is actually mandatory. Yeah, every patient needs to be evaluated on a multidisciplinary team, whereby we have different cadres looking into the care of these patients so that we can ensure we are getting personalized care for these patients and ensuring that we get good outcomes. Also, there's the integration of cancer research programs in these facilities offering cancer treatment services. I think we've all seen in the past 10 years, we've really made big steps in terms of cancer management. So how can we leverage on this to learn something? What can we do in terms of research in these facilities? What are we learning from the patients who come to these facilities, from the care that they've received, from the outcomes that we've seen across the centers? So research programs are also very important. So on the second objective, on improving availability of the human resource, the first strategy is improve availability of human resources for health. So some of the activities under this, we need to develop an oncology HR development plan. We need to strengthen oncology training plus scholarships. This is to increase the pool of oncology HR, whereby they can get training both locally and also out of the country. Also, we need to support development of HR sharing mechanisms. As we've seen, we have some health professionals who are maybe in counties that are not offering cancer care, but you have someone who has already trained in oncology. So how can we share the HR from that county to the next county that has the cancer center? So we need a mechanism for this. Also, the development and review of schemes of service for the oncology cadres. We've seen we are getting new oncology cadres which were not there before, and some of these actually don't have a scheme of service. So these need to review and develop a scheme of service for them. Okay, on the second strategy, in terms of HR, we need to strengthen the capacity of the oncology HR for quality service provision. And this will be done through establishment of continuous professional development programs that enable mentorship and regular in-service training. I believe that is very important. We need to always ensure that we are doing capacity building for our health workforce. Also develop cancer training packages, promote utilization of digital platforms for capacity building of healthcare workers. And on this, the Ministry of Health has the MOH Virtual Academy. We are going to post the link on the chat box so that you can all exploit. We have cancer materials on that platform. As we had said in the beginning, cancer care needs to be very timely. So sometimes you find the patient has been coming to the facility over and over. They're being managed for the presenting symptom, which is maybe, let's say, constipation. And by the time this patient is referred for further workup and cancer is diagnosed, it has already progressed. So it's very important for our primary healthcare workers to understand which are these presenting symptoms that may pinpoint to cancer, and so that they can refer this patient in good time. So we would urge you to look at these digital platforms that the ministry has launched so that you can get your knowledge on this. There's even a Google Play Store application that you can download. It's called the M-Saratani. So on that, you can get CPD platforms, you can get certificates as you gain knowledge on the different cancer types, how to diagnose them, the signs and symptoms, the basic management, so that you can also assist your patients. So on the third strategic objective here, we would like to increase access to timely, comprehensive cancer care services. So how do we do this? The first strategy is to improve the availability of cancer treatment services. So as I had highlighted, we have around 12 regional cancer centers, which are offering cancer treatment across the country, as well as the 3 referral facilities. So the other activities listed here are that we need 5 more comprehensive cancer centers. And you've said comprehensive cancer centers are those that have the 3 main modalities of cancer treatment, that is surgery, chemotherapy, and radiotherapy. Also, we'd like to strengthen the national referral hospital services and hemato-oncology. So this would like to ensure we can get more cancer treatment services offered at these referral facilities, as well as any new technology in terms of cancer treatment we can explore at these referral facilities. Also, optimizing digital health platforms at the Ministry of Health, utilization of telehealth in cancer care. I believe we are all aware how telehealth is coming up in the global platforms. So we need to leverage on this so that wherever the patient is, they can get cancer treatment services. Also, strengthening patient navigation. I know the KNH is big on this. They've been able to set up a proper patient navigation program, and this has really helped patients. As we all know, this cancer treatment is a long journey, and the patient sometimes just needs to be guided. Where do I go next after this? What do I expect there? And without this navigation, most patients become discouraged. They even decide just to go home because they feel there's no one who's supporting them. So we would like to implement this patient navigation across all our cancer centers to ensure our patients get quality care. Also, the framework for radiotherapy and nuclear medicine infrastructure, this needs to be developed. And in terms of financing for cancer treatment, we need a mixed financing model for cancer treatment by NHIF, as well as utilization of the Chronic Diseases Fund. The second strategy in terms of timely comprehensive cancer care services, we need to strengthen availability of palliative, rehabilitative, and survivorship services. So the activities listed here include the need to harmonize palliative care curriculum. We also need the development of cancer hostel facilities at the cancer treatment centers. We all know services such as radiotherapy require a patient to stay there, to keep coming back for around 6 weeks. So we require hostel facilities for these patients. We do not want to see the picture of patients having to lie on the benches as they wait for the next day because they cannot even afford, most of them, they cannot afford to be put up anywhere else. They don't have relatives in that town. It's too costly to keep going back home and come back. So the hostel facilities are very important. Also, we need regulations to guide appropriate opioid prescription. as well as improve the availability of oral morphine for appropriate use. Another strategy in terms of the comprehensive cancer care, we need to improve the childhood cancer treatment, palliative care, and survivorship and rehabilitation. As I had mentioned, according to the Global Initiative for Childhood Cancer, we are trying to get the survival rate of our children with cancer to 60%, and this is by the year 2030. So the activities listed here is that we need to operationalize the Childhood Cancer Technical Working Group. And this is very important. As I had mentioned, a technical working group provides guidance. These are experts in the field of childhood cancer. They're able to guide the ministry on what needs to be done. Through this group, there's coordination of the activities so that we don't have a lot of duplication of roles here and there. And we're able to put all our forces together to be able to get better outcomes. Also, we need to implement the pediatric cancer differentiated care package by NHIF. At the moment, the pediatric package is not comprehensive. So as much as someone has NHIF for their child, they still have to top up, and would like to see that the care package is comprehensive, whereby the child is covered for all their treatment sessions. Also, we need to support implementation of pediatric oncology centers of excellence with their respective hostel facilities. And this will be very important so that wherever you are, you know, if you find a child where you suspect they have cancer, you are able to refer them to this oncology, the pediatric oncology centers of excellence. Then there is provision of pediatric cancer management at the regional cancer centers. We've seen some of these regional cancer centers have become very good at offering cancer care, like Nakuru, Mombasa, Jaramogi Oginga Odinga. They've become really busy. We're having a lot of patients being managed at these facilities. So how about we also offer some pediatric cancer management at these regional cancer centers? Also, we need to have an efficient system for the referral of children with suspected cancer to the regional cancer centers and to the centers of excellence. And this is very important. If you don't have a proper channel for the referral of these children, it becomes difficult. They hang around in their facilities without getting proper care, and this delays their treatment. The last strategy under the comprehensive care services includes the strengthening of the supply chain of oncology health products and technologies. And we are all aware we cannot do without these health products and technology. So some of the activities listed here is that we need to strengthen the supply chain TWG. And I think I can't emphasize this enough. This team of experts are very useful to guide the ministry on what needs to be done, on what commodities are essential for our cancer patients, and how we can manage the supply chain. Also, we need to provide guidance on the essential cancer HPTs, and this is guided by the technical working group, as well as affordable oncology HPTs. So in terms of the pricing of oncology products, we've realized most of these products are actually innovator products. So their cost is pretty high. And there needs to be other ways that we can get these products to be affordable. And there are many ways that the experts have guided us on this that we're going to explore, including local production, including pooled procurement of oncology HPTs, and as well as partnerships where we get access programs for the essential oncology drugs. Also, we need to collaborate with the PPB in terms of regulation and ensuring the quality of the oncology HPTs. Also, we need to collaborate with KEMSA to ensure consistent availability of the essential HPTs for treatment, palliative care, rehabilitation, and survivorship. So I've come to the end of the pillar 3. Any questions can be posted on the Q&A. Thank you.
Yes, thank you, Dr. Joyfrida. And that's a very good presentation. And also thank you for introducing us to the digital platform, the Saratani and the Virtual Academy. I can see questions are coming in, but we'll be patient and have our plenary at the end of the presentation. So we will welcome our second presenter, Tony from National Cancer Control Program. Welcome, Tony.
Okay, thank you, Lillian. And my name is Tony Chepkwony. I'm a Felter President at the National Cancer Control Program. And I'm going to be making a presentation on Pillar 4, which entails cancer advocacy, partnership, coordination, and financing. So we'll first look at the overarching goal, of which is meant to forge and support effective advocacy and communication in order to ensure that there is partnership and mobilization of resources for a robust cancer control response in Kenya. So this should be an all-inclusive, or to ensure that we have an inclusive and comprehensive way in which we can have activities to ensure there is the influence of public policy, and in terms of even having laws and even assigning budgets for cancer activities across the country. So as an introduction, when you look at the context of this, we find it that we are dealing with scarce healthcare resources. So this is in terms of a public expenditure being at 2.2% of GDP. So when we look at resources from our own pockets, that is from what we have, we have a third of total health expenditure. So there is a need for sustained advocacy to make sure that we ensure cancer control remains a priority, and also include activities that will help influence public policy in terms of law and even budgeting. So we also have issues to do with evidence-based selection of cancer interventions. So we should not only deal with any activity, but we'd rather focus on what has evidence. So there is the issue of stigma in many societies. So when we look at even the community, they consider cancer as a life-threatening illness. So those people, this really affects the health-seeking behavior of cancer patients, whereby those with certain signs and symptoms do not seek help because they are afraid of what others will say about it. So the issue of stigma should really be considered, and also the level of knowledge and awareness about cancer. So when you look at the knowledge in terms of what the community knows regards to cancer, this is an aspect that really should be focused on, because this acts as a major barrier towards screening, early diagnosis, and effective treatment. So in this eligible population are not able to know exactly what it is about cancer. This will really affect the staging in terms of screening time. And finally, we need to come up with a robust cancer communication a strategy, and this strategy, the communication strategy, will ensure that the issues to do with the stigma will be addressed. And also it will help in creating awareness at the level of the community so that we can have information about cancer, information about where they can seek services in regards to diagnosis, screening, and even treatment. So all this information will be able to be found in the communication strategy. So the strategy is, Pillar 4 is anchored into 5 strategic objectives. And for the first one, it's aimed to empower and also inform the population in terms of cancer prevention, cancer control, and cancer stigma. So for the first objective, we'll be looking at mainly the level of information and how we can empower members of the community in terms of prevention and control. So for the second strategic objective, we'll be dealing with strengthening engagement and partnership from the county level and even the national levels. So we need to bring together the national and the county levels so that we can strengthen engagement and partnership towards cancer. And for the third objective will be in terms of strengthening and operationalizing the national level cancer control coordination agencies. And for the fourth, strengthen partnership for cancer prevention and control at all levels within the sector. We also aspire to increase innovative, sustainable financing for comprehensive cancer prevention and control. So we need to really pull out resources from different stakeholders, different partners, different organizations in order to achieve a comprehensive cancer prevention and control. So for the first objective, which we mentioned as in terms of empowerment and informing the population with regards to prevention and control, and also the issue of stigma, are we looking at identifying and mapping of appropriate communication tools? So what are the activities that the program wishes to or foresees that really needs to be addressed? So for the first activity is to finalize the National Cancer Communication Strategy. So this is something that the program is developing. And once finalized, it will be able to at least address the issue of communication in regards to prevention, control, and even stigma. And also we need to create awareness of cancer-related stigma and disparities. So the issue of stigma, again, really comes up when you talk about cancer. We also need to engage multi-sectoral stakeholders to support cancer communication and even reduce cancer stigma. So different stakeholders within different sections will be engaged so that we can all support each other to ensure that there is reduced cancer stigma. Development of evidence-based interventions that will help improve the outcome among priority populations. So when you talk of priority populations, we're looking at genetic predisposition. We're looking at family history. Yeah, we are looking at the immunocompromised or even the age-specific populations. So all of these are priority populations. So we really need to focus on them. We also have the issue of low income. Some of the population cannot access healthcare, due to maybe limited access to resources. So others probably could be from occupational risk groups. These are people who work in industries, those who are exposed to carcinogens. So all these fall under the group of high risk populations. So we also need to look at development of cancer screening, diagnosis, and treatment services directory that is publicly available. So for this directory, it will be able to address the issues of screening, diagnosis, and treatment, so that all these services can be found in this directory. For the next is mainstream advocacy, communication, social mobilization on cancer across all sectors. And for the first activity will be train. We need to equip, mentor the community health resource persons to increase awareness in the general public. So when you look at the community level, this is a key area that we really need to address, because these are the people who have the information exactly what is happening amongst our populations. So we aspire to make sure that we train them at the community level, so that we can even equip them and mentor them, so that they can address these issues and even refer those that are eligible to the service provision points. We also look at conducting stakeholder capacity building at the national and county level in regards to advocacy, communication, and social mobilization. So stakeholders will be key from different sections. So whenever they come together, we ensure that there is a capacity building among the national and even at the county level. Mobilize political commitment, involvement, accountability, and resource advocacy and communication activities. So in terms of course, there needs to be political commitment, so that we can mobilize resources, and for the resources that are availed, how can we account for these resources? So this is a commitment from the various stakeholders, so that at least we can have a robust way in which we address the issue of cancer here. We also need to involve persons living with cancer, the caregivers, and the community leaders in cancer advocacy and communication. So in all this approach, we really need to bring about the cancer, the people who live with cancer, because at least these people will be able to bring out exactly what they have gone through, so they can even encourage each other.
Sorry, Tony, we are not able to hear you.
Oh, sorry.
Kindly check on your network.
Okay, fine. Are you able to hear me?
Yes, now we can.
Okay, sorry for that. So we were looking at how we can involve persons living with cancer, caregivers, and community leaders in cancer advocacy and communication. So people who are living with cancer and even the caregivers, this can be good testimony in terms of passing information and even encouraging each other, so that at least we can address the issue of stigma within those with cancer. And finally, working with communities to reframe cancer services and cancer-related messaging, so that they do not stigmatize people or behavior. So in terms of the messages that we pass, we really need to look at what message we are passing. Whatever message we are passing should not be able to in any way stigmatize people or the behavior of other people. Probably people may be engaging in risky behavior that maybe could predispose them to cancer. So we should not pass information in a way that will stigmatize these people. Otherwise, we need to reframe this communication in terms of looking at how do we pass this message accordingly. Looking at promotion of knowledge, sharing within and outside the health sector on cancer, the first activity will be to conduct a National Cancer Summit every 2 years. So for the strategy, is envisioned to ensure that we have a National Cancer Summit every 2 years. We also need to provide support for counties to implement the National Cancer Control Program strategy. So without support, without mentorship, without financing, we cannot live to our dream of ensuring that this strategy is implemented at the county level and also nationally. So we really need to focus on how do we partner with these counties to ensure that the implementation of the strategy is something that becomes a reality. We need to also observe priority cancer commemoration days from the community level. So there are those days that we look at commemoration of cancer. So like, for example, the World Cancer Day, there is the Cervical Cancer Awareness Month. So we need to really prioritize these commemoration days, because these are the avenues whereby we are able to create awareness also, and even ensure that we address gaps that may be at the community level. In terms of strengthening of supply chain management, and that is for cancer prevention and control, we'll be looking at health products and technologies all levels. We are envisioned to develop a dashboard, and this dashboard will help us to track availability and even look at what do we aspire, what are the numbers that we aspire to expect in the future. So with the tracking of these commodities, we're able to quantify the use of the health products and technologies. This also includes not only the commodities, but also in terms of equipments used in cancer diagnosis and treatment. And this dashboard will be of great help, so that we can at least envision to ensure that we track on what commodities we have, what we may need in the future, so that at least healthcare services can be running without the issue of stockouts. So we also look at ensuring availability of commodities, equipments, infrastructure at the health facilities. So these commodities used for screening, commodities used for treatment, the drugs, the equipment used in diagnosis, this should readily be available at the facilities within the counties. There is the review and update of essential cancer prevention and control commodities and supplies in the Kenya Essential Medicines and Supplies list. So we need to review and even ensure that we update this list, so that it may be in terms of it may be available or readily available whenever these commodities are requested. And finally, will be to support local manufacturing of commodities and technology transfer and nurture innovation. So whenever we support local manufacturing of commodities, this will really influence innovation It will be an avenue for research, and thereby we can open up opportunities to people and even engagement of even partners in terms of innovative activities. Looking at strengthening of cancer control coordination structures, the first will be implement the NCD, that is the Non-Communicable Diseases Coordination Framework, and also strengthen the cancer TWG. As Dr. Joyfrida mentioned, TWG will involve the various stakeholders, and this coordination framework will help strengthen these TWGs so that we can implement and even look at the various aspects that need to be addressed within the strategy. We also know envision and this should be a member of the county NCD committee. We also convene regular coordination meetings with the counties, and these meetings will help to disseminate cancer policies. So regular coordination of regular meetings within the counties will help cascade this information to the county level and to the facilities that are down there. We also look at the development of a mechanism for sharing regional cancer control resources between counties, human resource, infrastructure, and also commodities. So there should be a mechanism on how we are going to look at these resources. How do we share them within the counties? The issue of human resource, because without adequate human resource, it will be hard to implement the strategy. So how can we share up the available resources to the counties based on disease burden? How can we share the infrastructure despite the challenges that we may be facing, and even the commodities? And finally, ensure continuity of essential cancer services during emergencies and pandemics. When we look at the issue of pandemics, whenever there is an issue like the COVID, how can we ensure that cancer care is not compromised because of these emergencies? How can we ensure that these patients continuously receive treatment? They continuously receive screening and other services, despite the fact that we are facing a pandemic. On strengthening the cancer control legislative framework, the first activity will be to amend the Cancer Prevention and Control Act of 2012. And this will be aligned so as to identify the various key roles in the spirit of devolution and even address the emerging needs. What is coming up that is new? How do we define these roles to ensure that they are aligned to amend to the Cancer Preventive and Control Act of 2012? Secondly, will be to amend the Alcoholic Drinks and Control Act so that we can increase excise taxation on alcohol. We note that alcohol is one of the modifiable risk factors that may predispose someone to probably liver cancer, esophageal cancer, and even other different types of cancer. So how do we amend the Alcoholic Drinks Act so that we can increase excise taxation on alcohol? That will be to review the Narcotic Drugs and Psychotropic Substances Act and development of appropriate regulations to improve access to opiates for use by cancer patients. So for example, morphine, which will help, which really helps in terms of alleviation of severe pain in cancer patients. how can we review this act so that at least we can improve the access of cancer, of these drugs by the cancer patients who may need them. We also need to look at supporting enactment of legislation to reduce the marketing and advertising of unhealthy foods and drinks. For example, the processed foods. How can we support the coming up of laws that will help the marketing of these unhealthy foods or processed foods that may predispose our population to cancer? Yeah, so we need to look at how can we address this. And finally, it will be to integrate cancer interventions in the counties, annual work plan, and integrated development in planning processes. So integration is very key within the counties. So whenever the counties have a work plan, this should be integrated in the entire planning. Another strategy will be to optimize the operation and operation capacity of the NCI, that is the National Cancer Institute of Kenya. So one will be to establish human resource instruments and recruit adequate staff. So as I mentioned earlier, without adequate human resource, it will be a challenge dealing with most of these aspects. So we need to pull up resources to ensure that there is adequacy of staff across all these service points within NCI so that we can deliver on the issue of cancer, the continuum of care. Second will be to build the capacity of the institute staff to deliver its mandate. So capacity building is another thing that is coming up. So we really need to capacity build the staff at the NCI to ensure that we deliver on the mandate. Support of the appropriate infrastructural establishment and also equipping of the National Cancer Institute as a learning resource. So this is a learning resource. This is a place whereby we can have various learning platforms. This is a place where we can do capacity building. This is a place where we can even do research. So we envision to ensure that the NCI acts as a learning resource. Finally, will be to advocate for the establishment of a multi-sectoral cancer response advisory committee. And this will be able to help address cancer on multiple fronts through coordination by the NCI. On strengthening the National Cancer Control Program, that is NCCP, the first activity again will be adequacy of staff. So deployment of adequate staff to deliver its mandate as per its internal operational structure. So staffing is another issue, and we need to have adequate staff being deployed so that we can live to ensure that this strategy is accomplished. So second will be building the capacity of NCCP staff to deliver on its mandate. So that is again, just like NCI, capacity building. Facilitate the NCCP to conduct capacity building, provision of technical support, and support supervision to counties for cancer control. So the program wishes to do capacity building within the counties and even provide technical support whenever it's needed, so that through these supportive supervision visits, the counties, we can address some of the challenges that could be present at those levels, and even make sure that the clients get quality care in regards to cancer. finally will be adequate resources, development and regular dissemination of cancer prevention and control policies and guidelines. So resources need to be pulled to ensure that these guidelines, these policies with regards to cancer screening, treatment, and all the protocols, these guidelines are disseminated at all levels. On strengthening a multi-sectoral partnership in cancer control, the first activity will be to establish an NCD, that is a non-communicable diseases, or a cancer control unit in all ministries, departments, and state agencies. At least for each and every unit, either ministry, or department, or state agency, we need to establish an NCD, or rather a cancer control unit. Next will be to conduct stakeholder mapping and strengthen public-private people partnerships. So this will really help us to ensure that we enhance cancer control across the continuum of care. Promotion of strategic collaborations with regards to cancer health products and technologies, manufacturers to ensure or rather to enhance access to quality and affordable cancer commodities. So these health products and technologies that we require, we need to ensure that they are first of good quality, and at the same time, we need to have them being affordable, so that at least they can be accessed by various service providers, so that we don't have to refer our clients from this point to another point, bearing in mind the cost of living and probably their nature, probably they cannot even afford care. So we need to ensure that these commodities are available, they are of quality, and they are affordable to this community. And finally, to work with the regulatory bodies that will see to it that we streamline processes in terms of reviewing, evaluation, and clearance of new cancer screening, diagnostic, and treatment products. So this will also include those for research and even for the clinical trials. So these regulatory bodies need to be brought on board so that we can ensure that we streamline each and every process, that we'll see it that we improve on cancer screening and even diagnosis and treatment. On the strategy for strengthening innovative financing mechanisms for an effective cancer response, the first activity will be to look at increase in public financing for cancer control. That includes the universal healthcare benefit package. How do we increase public financing in terms of even including the aspect of UHC? Second will be to leverage on the chronic diseases fund so that we can be able to help boost the provision of the necessary cancer medicine, health products, and technologies. So we need to utilize the chronic diseases fund so that we can be able to support in terms of availability of this essential medicine and health products. Adoption of a mixed financing model. So we need to focus on a different approaches in terms of pulling in resources that will help create a model in terms of looking at the private sector, we look at the public sector, and even partnership and access programs. So the idea of bringing in all these stakeholders will be able to help provide a solution in terms of cancer prevention and control. Because when you work with different stakeholders, the outcome will definitely be better. So looking at the support, this will be in terms of how do we support the county governments so that we can create annual work plans. And out of these work plans, we can be able to allocate budgets. We can be able to allocate resources. We have budget lines so that we can entirely tackle the issue of cancer prevention and control. Advocacy is also key in terms of consolidating finances. So this will be from different levies and even taxes in order to support cancer prevention and control. And next will be lobbying for NHIF to enhance the diagnostic package for radiology, or pathology, and lab sciences. So we lobby for to ensure that NHIF will be a package, will give a package that will cover not only radiology, but also pathology services and even the lab services, so that we cannot have patients not seeking treatment simply because maybe they don't have resources. And last will be ensuring adequacy of financing towards achieving a 60% survival rate for children with cancer. So Dr. Joyfrida had mentioned this, that 60%, we intend to achieve a 60% survival rate for children with cancer. And the first point will be advocacy. That will be with regards to provision of sustainable, comprehensive care for children. Next will be in terms of UHC coverage, where we envision to have a differentiated care package specifically for the children. We also wish to institute mechanisms, and these mechanisms will help us to finance the procurement of commodities, that is in terms of cancer medicines, rehabilitative products, and other health products and technologies that may be required with regards to care of children with cancer. And finally, will be creation of a social protection package for childhood cancer patients and also their families. So thank you so much. That is the end of my presentation. Back to you, moderator. Thank you.
Thank you, Tony, for elaborate presentation on cancer advocacy, partnership, and financing. Now I'm seeing the time has gone, but we can still go through the plenary session. We see the questions that if our panelists could answer them. So I'll read the questions as they are for our panelists. The first one, sorry. Okay. The issue with the public facilities is the long queues. I had a patient who was referred for radiotherapy at stage 3, but But by the time they were starting treatment, they had gone to stage 4. They need to start investigations from scratch, like all other investigations were not good enough, is really time wasting. I think that's just a comment. Yes, Kennedy is also having a question here. A comment. We appreciate the good work done by Pillar 4. However, the components of diagnostics with the challenges of histologies and CT scans may not make it easy for the clients to utilize treatment. Kindly comment. That one I think is for Pillar 4. Let's take another one, and then probably can be answered together. Then Bretta is, okay. I think Bretta wants, okay. The next one is a lot of changes in terms of treatment it's ongoing, especially for the breast cancer. What are the national plans on clinical trials? I think that one goes to Dr. Joy Frida. Okay, this other question is, at what level will the centers of excellence be categorized and will be based on the KQMH scores of above 80%? That one, it's from Dr. Kibias. I think maybe we take those first questions. We start with the first question for Pillar 4. Kindly, Tony, you can answer the first question. I don't know if you heard me. If you're not ready, we can go to Dr. Joy Frida. You can answer the question on a lot of changes in terms of treatment is ongoing, especially for the breast cancer. What are the national plans on clinical trials?
Okay. So on the clinical trials front, we are aware there's some work going on that. I think NCCP has been partnering with one of the stakeholders to do some clinical trials on this, as well as the ICI. So there's some work going on around this, and in terms of what the program is doing in these trials, I can say we are part of the consultative team that participates in the drafting of the protocols. Our stakeholders are involved in this, and as a ministry, we are also able to offer some guidance on the protocols to be used. Although this is an area also that has a lot of players. We have very many other players that are on board on this, and as a ministry, our work here is more of coordination and that of guiding the teams on the best practices. In terms of the centers of excellence, it's true, Dr. Kibias, the KQMH is going to guide us so that these centers actually attain a high score. We are not sure about the exact percentage that they need to score, that one will be deliberated once we actually reach that stage, but we're going to follow the guidance of the KQMH. Okay, thank you.
Okay, thank you, Dr. Jefrida. Faith Muchai is saying pharmaceutical technologies should not be left out as trainings for other cadres are being initiated. I think, Faith, I'll answer that. That is noted. And then we have Farida saying a lot of great information. Where can we get the ministry document? We have the ministry website where you'll get these documents. Okay, another question is, please confirm whether the radiotherapy section at the Coast General Hospital is functional. Okay, that one will go to Dr. Joyfrida. Okay, there's another question here from Judith Okot. Will nutrition care also be considered in the management? Yeah, I think that one also is a question which is noted. We'll discuss it and consider that, because nutrition is also part of treatment. So I think, Dr. Joyfrida, you can take the question that was asked about Coast General.
Yes, the therapy services at Coast General have been running for roughly 1 year now. It's a very busy center, around 60 patients per day, but the wait time is not too long, roughly around 4 to 6 weeks to start treatment. Okay, thank you.
Okay, thank you.
I think Tony is ready to respond to that other question.
Which question?
Okay, let me respond.
Okay, please go ahead.
There was a question on pillar 4. Yes. Okay, fine. There was a question with regards to challenges with histology and CT scans. I can respond to that, though that will be on pillar 2. And looking at the previous strategy, that is 2017 to 2022, we realized that that did not do so well. But in the current strategy, pillar 2 is prioritizing the issue of histology and CT scans. That is majorly in terms of boosting diagnostics and follow-up of patients. So this is being prioritized as a key area, but within pillar 2 of the strategy. Thank you.
Yeah, thank you, Tony. Okay, we'll go to another question, take some more questions from Professor Ronald Wasike. One of the greatest challenge to both patients and caregivers is the cost of immunotherapy agents or targeted therapy for cancer. What is the ministry and or KEMSA doing to bring affordable molecules for our patients? I think that is going to Dr. Joyfrida. Joyfrida, you can go ahead if you're able to answer it immediately.
Yeah, so I believe I'd mentioned this, that most of the oncology products are actually innovator products. So this means these drugs are still new in the market. So even the number of manufacturers for these drugs are not many, so the cost of the drug becomes high. But on this end, there's some work that the ministry has been able to do. Like we have the Herceptin subcutaneous, where we were able to get into an access program with Roche, and they were able to give us a very good access price, whereby the patients are able to get this drug for all their cycles that they need, and it's covered fully under NHIF, and the patients do not need to top up anymore. And this was after seeing that previously the cost of that drug would be close to 100,000 per cycle. And now it's been slashed down to 35,000, and the patient is able to get all their subsequent cycles without any top up. So there's a lot of discussions that we are having with our pharmaceutical companies around this, so that they're able to give us access price to be able to help the patients not incur a very high cost. Thank you.
Okay. We have a question from Bretta. Bretta is saying that NFM local radio station in McQueen County has offered 4 hours.
Lillian, are you speaking?
Oh, yes, I am. Are you able to hear me? Hello?
Yes, we can hear you now.
Okay. Yeah, there's a question from Bretta Mutisia that says NFM local radio stations in McQueen County has offered 4 hours per month on cancer education awareness, advocacy, and involvement of cancer survivors. And saying, Mr. Tony, how are you going to partner to maximize this opportunity? And then there's a question here that kindly update this session on the portal. Not available, even last meeting was unavailable. I don't know whether it has been uploaded. Another question for Tony. For Mr. Tony, great tackling of Pillar 4 of cancer fight, along stigma related to cancer management or rumors and I think I don't understand that one. Yeah, I think our time kind of has ended, and we have many questions, but I can see some are congratulatory messages. Most of them are general. Yeah, like there is a question from Charles Barasa. Let me just pick this one. If a patient's not able to pay cash and NHIF not mature, what can you help the patient as it matures? I don't know if this question is directed to the strategy or to the National Cancer Control Program, because if NHIF has not matured and the patient is not able to pay cash, probably maybe the facility, I don't know if they can consider as the, I'm not able to answer that one. Dr. Frida, are you able to answer that?
Unfortunately, there's, I can't say there is a solution to that. So that's why we advise patients to be on NHIF even before the treatment, before the diagnosis. It's good that they be active members of NHIF because actually that has been noted to be a cause of delay in treatment initiation, because when they're required now to start off treatment and they don't have an active NHIF, and they're not able to pay cash, it becomes difficult because some of these drugs, like the drugs we supply the cancer centers, the regional cancer centers with, if you are lucky, if the regimen that you've been put on is among the drugs being supplied by the Ministry of Health, then they can actually start you on those drugs without any charges. But in case your regimen includes other drugs that have not been catered for by the ministry, it becomes difficult. And that is where now you have to wait until your NHIF matures.
Okay, thank you, Dr. Joyfrida. Mandela Ogada is asking, can NHIF be expanded to cater for diagnostic tests so as to facilitate early detection? I think Dr. Joyfrida, I don't know if you had mentioned it, maybe you can mention on that too.
Yes, that is under Pillar 2, but also as part of just making timely initiation to care. This is an area that NHIF has been engaged to support. Currently, they've actually accepted to support some of these diagnostic procedures. Not all of them, but some of them have been accepted because they also say due to the limitation in the contributions that they receive, they're also not able to cover a lot of these tests. But we are still negotiating with them to ensure that they can be able to cover at least a good number of the diagnostic tests.
All right. Thank you, National Cancer Control Program team, Dr. Joyfrida, Tony, and Lillian. We thank you for your quite insightful presentation, and you guys are always welcome on the platform. As we are closing, we'd like to let you know or make you aware of this highly anticipated sessions that we're going to be having. One is going to be today in the evening for us from 7 p.m. to 8:30 p.m. East African time, where we'll be discussing achieving WHO's 2030 hepatitis B and C elimination goals. This is as we prepare to join the rest of the world in commemorating World Hepatitis Day tomorrow. So kindly join to have more insights and that you can share with the rest of your teams and other colleagues as we commemorate World Hepatitis Day tomorrow. The other session will be a symposium that is set to begin tomorrow at 7 a.m. to 5 p.m. It is the Wound Care Symposium, where they'll be discussing an array of topics, including latest research in wound care and management. They'll also be launching the highly anticipated WSCSK textbook, that's the Wound Care Society of Kenya textbook. This will be the first in its, the first textbook, or rather guidelines, that will be launched in the country. So be sure to join so that you can get this information and also share with the rest of your teams. Thank you for joining us for today's webinar. We're looking forward to see you in the evening as we open for the hepatitis session. Thank you and goodbye.